That should be it.
My name is Rodney Bowling. I'm the Chief Science Officer of Tukira Rose Rare Lab. We do preclinical proof of concept work. We start by building a toolbox. In your toolbox, we start by collecting a genomic sequence. We collect blood, make cell lines. We make mice, if applicable. We do CRISPR corrections, all to get down to one of these three paths. We have 15 families that we're currently working with. These 15 families, there are 12 different genetic disorders. And I will show you an example of an antisense oligo, a gene therapy, and a high throughput small molecule screening. Here's Casey and Rosie. You've seen Casey. This is an example of an ASO that both knocks down HNRNPH2, H2, and we see a corresponding correction in H1. This was an example of a success. This drug would work to help probably roughly 5,000 people. Here on the left, you see a lysosomal storage disorder that is caused by loss of function in SPG11. This is a cell line from Melinda. Melinda was 17 years old, walking across campus. Her right leg kicked out from under her and proceeded to have a seizure all its own. The name of the disease is spastic paraplegia, correctly named, but sinister nonetheless. Melinda will not make the age of 40. This gene therapy, you can see correct the lysosomes red in the left to right. You see the graph below. This young man here is Simon. Simon, we took cells from Simon and have run a small molecule study looking for anything that would help him with a different lysosomal storage disorder called Sanfilippo B. And we found a series of 10 small molecules. 3 of them I have hope for moving forward that will maybe knock down his lysosomal storage disorder by 60%. My team is here. Netta is, stand up, Netta. So Netta's official title is Queen of the Lab, and Justin, who's here as well. If you have questions, please talk to one of the 3 of us. And our fearless leader, well, there he is, Casey.
Walk us through just logistically what it looks like when a family shows up at your door and says, "We have rare disease." Like, what's the process from that point on?
And that process has changed a lot. One of the things that we found is patients will come to us with a whole exome sequence that will have identified the wrong disease. So very early on, we run an amenability study to look and see, do you have the disease that you believe you have? If you do have that disease, of these 3 modalities, which of these 3 modalities will work for you? From there, it's collect blood, make an IPS cell line, do the CRISPR controls, get a mouse started to match your disease as early as possible, because that mouse will take as much as 18 months, and very quickly go through and make a proof of concept for that disease. Yes, ma'am.
I know we'll be talking about
Tomorrow.
That's something, and that's not a question I expect you to answer. But I think that a general problem that would be.
Okay, great. On that note, the only way I know to take that to the clinical space is what we're doing tomorrow. Is I bring you the data that I have and we discuss it. If you and I believe that we have a way forward, then we bring the mother in and let you talk with the mother about the small molecules tomorrow we're having this meeting about Simon, about the small molecules that we've identified. And do you as a physician feel comfortable moving forward with the options? And then give you the opportunity to talk to the mother. These are the options. These are the side effects. This is the cost. And how do we move forward from here?